everyone. I'm Amanda Reddy, the Executive Director of the National Center for Healthy Housing. And for the last 2 decades, a big part of my work has been learning and deepening my understanding of how we can more effectively partner and collaborate with our healthcare system and with healthcare payers on improving housing quality and health outcomes. So today I'm going to be really pleased to share with you, a really high level overview of the opportunities surrounding healthcare financing of healthy homes, and really thinking about what that outlook looks like right now at this moment in 2025 and beyond. Sometimes when I do this work, the first reaction I get from people when they hear words like healthcare financing is like, wait, I'm not a healthcare provider or a managed care plan or an economist. And I want to say that's okay. You're in the right place. I'm not any of those things either. I'm an environmental epidemiologist by training who had to sort of figure out and learn this world of healthcare and healthcare financing, so that we could better partner and collaborate to improve health outcomes for folks. So I promise it's doable, and there's lots of help available to help you navigate that space. And lately, if I'm being honest, the question I'm asked even more readily than that is this even the right moment to be talking about partnering with the healthcare system when our healthcare system might be about to undergo radical transformation? And I want to assure you that it's not only still important, it's probably more important than ever, and that this isn't the first time we've faced this kind of uncertainty. You see on screen here a post-election analysis blog I wrote that really makes this point that this work is still hard, it's still possible, it's still important. But pay attention to the date up here. This was a blog I wrote in 2016 when we faced a similar moment of uncertainty. And, back then and now, I think, I want you to hold in your mind a couple of things that are still true. It's possible that our healthcare system and our Medicaid system in particular may be about to undergo transformation, but we still don't know yet what might or might not happen at the federal level. And it's really important that we don't, proactively and preemptively sort of give up our efforts to advance this work. It's also true that even if we do see radical shifts in the Medicaid program at the federal level, that there are still significant opportunities that exist at the local level, both within that system and outside of it. And that we can also use this time to lay the groundwork for more expansive plans to partner with the healthcare sector later on. I think, in fact, the past 20 years has shown us that sometimes in these moments of uncertainty, or when healthcare trends nationally have shown a retreat from investing in these kinds of services, that states and localities have stepped in to do some really innovative work. And sometimes that not only helps to build the infrastructure at the state and local level to do more later on, that those experiences become the really innovative pilots that all of us can build on when opportunities open up again. So this moment remains really, really critical for our work at this intersection of healthcare and housing. So, it begs the question, why? Why is housing healthcare, and why should the healthcare sector care so much about housing? I think many of us have heard that statistic that people spend about 90% of their time on average in indoor environments. But I think what people don't know, that sort of nuance of that same survey that generated that statistic, is that Americans spend about 70% of their time in residential environments, that a majority of that time spent indoors is in residential environments. And certainly that proportion can be even higher if you are a very old person, or if you are a very young child, or if you are somebody who works from home. If you have certain types of disabilities, you may be spending even more time at home. For instance, young children, I really credit our partners at the Children's Environmental Health Network for more than a decade ago bringing to my attention that a majority of children under the age 5 in this country receive their care in residential environments, whether that's their own home or a neighbor's home or another relative or family-based childcare. So that homes are really important early learning environments too. We spend a lot of time in these home environments, and our housing can impact our health in a lot of really profound and interrelated ways in terms of where our home is located and the physical environment and exposures surrounding us, whether or not we can actually afford to live where we're housed. Can we afford our rent? Can we afford our mortgage? Are we able to stay in the same place over time? The neighborhood characteristics and how safe and welcome and supported we feel in our communities, and certainly the quality and condition of our housing environments can also impact both our physical and mental health. And this dimension of housing quality and how that impacts our health and our opportunities to leverage that to really improve and transform health is where my organization focuses our work. So we spend a lot of time there. It has this incredible potential to impact and transform our health and well-being through a variety of different ways. This dimension of housing quality that I mentioned is quite broad in and of itself. There are a number of physical, biological, structural agents that can impact our health and well-being. A number of different housing conditions can result from how well our houses are constructed, designed, and maintained. Things like respiratory conditions like asthma and COPD and other things, lead poisoning, falls and other types of injuries, cancer, our heart and cardiovascular health, poisonings, mental health, infectious disease, even death, as well as many other types of quality of life outcomes, including whether children are able to go to school and thrive, and whether people are able to arrive at work healthy and productive. So our housing has a really huge potential to impact our health and well-being. It's also not uncommon that our houses and our homes are impacting our health. About 40% of US homes on average have at least one health or safety hazard that may impact people's health and safety. And this is true whether we're looking at metropolitan statistical areas in and around larger urban environments or whether we're looking at rural housing. It's also true that these risks are not equally distributed. I'm sure if I asked many of you and other partners in your state or community to sit down and give me a list of the communities or zip codes or neighborhoods where housing quality is substandard, where people are more likely to experience housing related illness and injury, things like lead poisoning and asthma, you probably wouldn't have a hard time generating that list. And it probably would look a lot very similar to the same list that maybe one of your community partners would generate. We also know another reason that the healthcare sector and us as a society should care about investing and thinking about housing as an important component of healthcare in this country is that these housing quality conditions that drive and exacerbate the disparities that we see in some of our most critical and pressing public health challenges, they're costly to our society. And the converse side of that is that when we invest in improving our housing quality and housing conditions, that we see significant return on investment. So you see on the screen right now some examples of the kind of returns that have been documented over and over again if we invest in things like improving environmental asthma triggers, addressing carbon monoxide, moving towards smoke-free housing, or investing in lead hazard control. And it's worth noting that these estimates likely underestimate the benefits of when we address housing holistically, that they are also often not recording all of the other benefits that we may be seeing for home values or improvements in energy outcomes or jobs creation that may be associated with this type of work, let alone some of the climate outcomes that may be of specific interest to all of you. So we have a real opportunity here. So it's pretty clear that the healthcare system should be paying more attention and there's a real opportunity here. Following through on that climate note for a minute and the opportunity here to really see some co-benefits between these housing investments and health and climate is that it's important to acknowledge that housing is part of the equation, whether we're thinking about adaptation or mitigation in terms of our climate work. It's certainly true that the residential sector accounts for about a fifth of our country's carbon emissions. So making homes more energy efficient is really key to a climate strategy. It's also true that homes are really central to our response to a changing climate. They're the place where most of us are going to take shelter from extreme heat or extreme cold events, wildfires, flooding events, high wind events, and more. And we have really, really significant research that demonstrates over and over again that when we make the right kind of investments that co-invest in both climate and health outcomes to improve housing quality, it not only helps those climate and health endpoints, but can also help increase jobs. It can increase home values. It can decrease energy bills, make homes more comfortable for their occupants, and much more. And I encourage you, if you're interested, to reach out and ask me more about, specific shovel-ready examples, like replacing old leaded windows with energy efficient windows, or decarbonizing buildings by removing gas appliances and replacing them with electric appliances, and how those can have co-benefits for both health, climate, and then many, many other important endpoints as well. So it begs the question, if it has all this potential and it's so obvious that we've got these shovel-ready, proven solutions, why isn't this happening more, right? Is this collaboration with healthcare just a theory, right? Or how possible is this? And just to give a little perspective on that question, more than a decade ago, back in 2014, an NCHH survey of all 50 states found that more than half of the states at that point, about 27 states, had some Medicaid reimbursement policy in place for either home-based asthma services or follow-up services to address the home environment for children with lead exposure. So even a decade ago, more than half of states had something in place this is just looking at a narrow slice of Medicaid reimbursement and just for lead and asthma. So this is not theoretical. We've been doing this for a long, long time. It doesn't mean that those policies have always been effective or implemented at scale, but it's not theoretical. We have more than 2 decades at this point worth of experience in getting this work done. And it's worth noting that many pathways have been identified over the last 2 to 3 decades of how to partner with and get financing from the healthcare sector to get this work done, ranging from individual partnerships and collaborations with individual managed care organizations, getting direct reimbursement from Medicaid, leveraging existing benefits like the early and periodic screening, diagnostic, and treatment benefit, leveraging mechanisms like 1115 waivers or state plan amendments to change the way that we deliver Medicaid services on either temporary or permanent basis, to test out different models of improving housing conditions, or partnering with nonprofit hospitals. If we had more time, I would love to go through everything that we know about how to put these kinds of services and use each of these different levers, give you more examples. But the links that are in the presentation should be available to you if you access the copy of the slides in the comments section below. And we also encourage you to follow up if you'd like more examples or want any more information about any of these mechanisms. I think it's also really important to note that in many cases, and in many of those examples and others that I just showed on the screen, that there are also other sustainable financing mechanisms outside of the healthcare system that can either be used as a complement to healthcare financing when a community or a state may just not be ready yet to put that healthcare financing in place, or where they've put it in place, but they may not be able to provide a full set of services. So it can either be a complement to or an alternative to healthcare financing, and can help lay the groundwork for more coverage and support from the healthcare sector. So some examples of other sustainable financing mechanisms that have been used again, either as a complement to healthcare financing or as an alternative to it in communities where healthcare financing may not exist. Include leveraging state general fund dollars, other types of healthcare dollars, like having a tax on hospitals that may be put into specific services, leveraging settlement agreements to provide financing for and startup costs for developing these types of programs. We've seen increasing partnerships from programs like home delivered meals programs, providing repair services or leveraging community paramedicine infrastructure to repair homes and assess homes for housing quality needs. Certainly, there are a lot of great examples that many of you are probably familiar with about how the energy sector, weatherization, and other programs can be leveraged to bring health into their framework and to really improve health outcomes for residents. And then just home repair programs, both existing home repair programs that may be national in scope, like Rebuilding Together or Habitat for Humanity, or local home programs at the local level. And we've seen some really exciting trends in home repair programs, increasing the caps on how much money can be spent per home, increasing the scope of the types of work that can be done so they can be addressing homes more holistically and addressing resiliency needs at the same time as we are addressing some of these legacy environmental justice issues, and expanding their services to be able to address the needs of rental units and renters, where traditionally maybe some of these programs have been focused more exclusively on single family homes. Again, all of these examples have links that you are welcome to access in the copy of the slides or to follow up with us for more information. But I want to take a minute just to focus a little bit on one specific mechanism that I mentioned here, which is hospital community benefits. So nonprofit hospital organizations in the US are required by the IRS to spend some of their surplus each year on community benefits, which are defined as goods and services that address a community need. And that community need is identified through a required part of this process called a community health needs assessment. Sometimes you'll see this abbreviated in documents as a CHNA. That just stands for Community Health Needs Assessment. So this is a requirement of nonprofit hospitals. It's also worth noting that although nonprofit hospitals account for about 60% of all US hospitals, that even for-profit hospitals may be a potential source of investing in these types of community benefits. One recent analysis suggested that for-profit hospitals may be actually investing just as much or maybe even a little bit more than their nonprofit counterparts, despite not having this requirement. So many of the same principles may apply here. As part of the Affordable Care Act, the IRS issued some additional guidance about hospital community benefit requirements, including articulating a list of community building activities that were eligible expenses. And you can see the first bullet on this list, which appears right in these tax documents they have to fill out, is about physical improvements and housing, really giving the green light for investments in repairing and providing housing. But many of the other items on this list may also be an important component of the work that you're trying to do within your community to build the infrastructure, to build more safe, healthy, resilient, and affordable housing. So things like coalition building and workforce development, policy development, many of these things are also eligible community benefit activities. And you see here on screen an article from the Center for American Progress really calling out this opportunity for nonprofit hospitals to improve community health through housing investments. And this article notes that there are a number of different ways that nonprofit hospitals can take action to really address the housing crisis that many communities are experiencing, including improving the quality of existing housing stock or building up the supply of quality, safe, resilient, affordable housing, investing in supports like rental assistance or legal aid services, medical legal partnerships, or even investing in efforts to advocate for policies that really strengthen and stabilize that's high quality, affordable, resilient housing. And just a couple of quick examples of how communities across the country have used community benefit dollars in this healthy housing space. This one is from more than a decade ago, again, just sort of illustrating the point that this is not theoretical or new. This has been around for a while. This is an example from 2013 from Lynn County, Iowa, where Mercy Medical Center supported the Children's Home Asthma Management Program to assess and provide services about environmental asthma triggers in the home environment. Another asthma example out of Boston Children's Hospital is their long-term support of going strong, I believe, for a decade or more at this point, for the Community Asthma Initiative, which again is a home visiting program that provides a full spectrum of care, including environmental remediation supports. And Boston has some great examples about medical legal partnerships as well that are worth checking out. Another example, more recent example here, comes to us from Lancaster County, Pennsylvania. This is an effort where there has been a goal identified of eliminating lead from 2,800 homes in the county over the span of 10 years, a commitment of $50 million to help achieve this goal, and really critically serving both single-family homes and rental owners, and serving families living below 400% of the federal poverty line. So some really important work here. Those of you who work in this space know that last bullet is really important because this means this program can address communities who may just fall right outside those eligibility requirements for other existing federally supported programs, but who are still really struggling and do need help to make those critical repairs to their home environment. So again, not theoretical. Communities around the country have been and continue to figure out how to leverage those community benefit dollars to improve housing conditions. And again, I just want to take a moment to reiterate the climate connection here, that as the intensity, frequency, and duration of all of these climate-related events increases, there's a parallel increase in the urgency of making sure that all residents have an affordable, safe, and resilient place to shelter. And I want to emphasize one more time that, a lot of us hear that kind of a thought and think about the homes being able to withstand those climate events and for people to be safe during and after the events. But there's a real opportunity here also to make sure that people are safe before, that they're safe all the time. And again, we have lots of great examples of how to achieve those kinds of co-benefits. So we have this enormous potential. It's well documented. We have shovel-ready, solutions available. We've got the economic data to say this makes sense to the healthcare system, and yet it's happening, but it's not happening at the scale that I think many of us would say that our communities really need and that our communities really deserve. In fact, a 2009 analysis of hospital community benefit investments found that only about 5% of community benefit dollars were being spent on direct community health improvements. And so even a smaller percentage of that was being spent on housing. Most of the money actually goes to charity care or to cover unreimbursed medical expenses. So we still are really not fully leveraging this mechanism. And, having done this work again for over the last 2 decades, there are a number of things that we can talk about, a number of challenges that may exist within a given community and even nationally that may make some of this investment difficult. But with hospital community benefits, I want to call out 2 particular disconnects that we see happen over and over again. One is, I mentioned earlier that part of this hospital community benefit process is the community health needs assessment that nonprofit hospitals have to go through on a regular cycle, and then their community benefit investments are supposed to match the needs identified by that community health needs assessment. What we've learned in studying this over that period of time is that a lot of hospitals contract out for their community health needs assessment to third-party vendors, and those third-party vendors often go just to sort of standard data repositories, places like county health rankings and others that have really good and important data, But those portals don't always have great information about housing quality. And the data often exists at the county level, which may mask disparities and needs at the sub-county level that are really going on. And so there's a missed opportunity to really even influence that community health needs assessment to surface housing as a potential platform for transforming community health. So that's one area where we see a disconnect happening, is that housing, they're just not looking at the right data, and they're not looking at the right data at the right geographic resolution that even gets housing on the table for consideration. So it's not always that housing is losing out to something else. It's just that it may not even be a major part of the conversation. The other thing is that I think we have seen over time from many, many different sources is that a lot of people, lay people, decision makers, and that would include folks engaging in the hospital community benefits process, understand the connection between housing and health, right? They don't need a lot of explanation. There was a great study done by the Frameworks Institute several years ago that examined this issue. Like, what do people know about health and housing? And what they found was people do understand the connection between housing and health. At the same time, people also think it's a big, complex, unsolvable problem. And it is complex, but it's not unsolvable, right? We do know how to find these hazards. We know how to fix them. We know how to provide people safe, affordable, resilient housing. And I think what many of us in this space have to, take from that lesson is that I'm a scientist by training, so is most of my staff. We're trained to spend 90% of our airtime talking about what the problem is, right? Trying to convince people that there's this connection and there's this problem. And we think that that's what we're doing. But really, many people are coming into this space already understanding that connection. And so we're not teaching them that there's a connection. Instead, we're reinforcing that second part of the thought. This is a big, complex, unsolvable problem. And so I think we have a real opportunity here to not just bring data to the table to help show that there's a problem in the community, but to also put a huge emphasis on the fact that we have plug and play, shovel ready solutions that can help to answer these community needs. And so just a few tips for getting started in a community benefit space, if this is a mechanism that you're interested in exploring in your community. First of all, just familiarize yourself with, like, what are the nonprofit hospitals in your community, in your area, already supporting. Look at what the community health needs assessments say. Look at what they're supporting now, what they've supported in the past. Just familiarize yourself with that. And there are some examples here in the slide about where and how you can track down that information. And again, if you get stuck on any part of this process, feel free to reach out for some help. Another really important part of this process is reaching out to build a relationship with the hospital's community benefit manager. And there's really no wrong time to do this. I can tell you, many times communities engage with me and we start looking at the process and we realize, oh, they just completed a community health needs assessment last year. Oh gosh, how many years are we going to have to wait before we have another bite at the apple? That's okay. This is a great time to start laying the foundation with this hospital community benefits manager and make sure that they understand that you are available to help them with their community health needs assessment next time around and with your shovel ready solution. So never a wrong time to start building that relationship and investing in that relationship. Again, and as you build that relationship, you can use that opportunity to collect more information about how the hospital engaged in their community health needs assessment the last time. What data portals were they using? How were they engaging the community? How do they like to work? How might you be able to help partner and provide data and get your data into the system and onto the table for consideration. As part of that, also, you may consider that maybe the community health needs assessment they did surface priorities that you have a solution to, and they're just not aware that you are an existing program out there in the community. So really think about, how you can make those connections. And I really just urge you to, just get involved. So again, that really means making sure that they are aware that you are available to help support that community health needs assessment process. You're not going and asking them, like, please address housing quality and that's going to create a lot of extra workload for them. Figure out how you can help them get access to that data, how you can help package it up so that you can make it as easy as possible for them. And again, really emphasize that you have specific shovel-ready solutions, right? You're not going to be necessarily asking them to invest in creating a completely brand new model. You've got something that they can just start investing in today, because I know that many of you do. And finally, a good message here is also ask for help. You don't have to reinvent the wheel. It's not just my organization. Lots of us in this space know this process well, know others who've been through it, and we can help make connections to resources or other peer communities who have been through this. So don't feel like you're on your own here or you need to reinvent the wheel. I'm not going to spend time on the next few slides, but just want to highlight that there are some additional resources I've included here around healthcare financing, around some of the climate co-benefits that you can help articulate and make this connection, around actually getting home repair programs stood up in your community, which again can be a great stepping stone. It can provide immediate impact and support right now, but it can also pave the way for lots of other healthcare investment later on, or other local policies that help to improve housing quality. And then reach out for help. You saw on one of the slides that we have coaching and technical assistance available. It's available for free and on demand, and can be used in whatever way that you need. If you just need like a thought partner to help assess what the opportunities are in your local landscape, if you just have questions about a specific mechanism, if you have an upcoming meeting with a nonprofit hospital or a Medicaid managed care plan and you want to strategize about that, or you want us to review your leave behind, anything that you may be experiencing, a specific challenge, maybe related to the workforce in your community to deliver these services at scale, and much more. Again, that help is available for free, on demand, very customizable, very flexible, and I encourage you to reach out. And to do that, I will leave this screen up and conclude here. My contact information is there. I encourage you to connect with our organization online. If you reach out to us with specific requests, please copy the email address for my colleague, Laura Fudala. Her email address is on the screen, and I hope that we hear from some of you.
Amanda, that was great. You can actually leave, if you wouldn't mind, leave that slide back up with your contact information, and we can do our Q&A right over that, if you don't mind.
Yep.
Yeah, this was absolutely amazing. Thank you so much. I feel like you were talking to me. I know you're talking to me, but I feel like you were talking to me as a real estate professional, and I've been licensed both in residential and commercial for the last 25 years, and also, an emerging developer looking to focus exclusively on healthy, smart, high-performance homes, leading with the healthy part, realizing that the energy reduction and the climate resiliency and the decarbonization will all kind of fall into place. I really appreciate the work and the research that your organization does under your leadership, and I really appreciate all the resources that you have available as well. So thank you for that. So, health outcome-based financing, creates lower hospitalizations, reduced emergency room visits, of course, with those with asthma, and gets kids back into school. I really appreciate kind of how you frame that, because asthma in Baltimore, 8th highest rate of asthma emergency visits in the nation, 2nd highest rate of asthma related fatalities in the country. And asthma is a big problem even in schools. Whereas there's what's called the asthma tsunami. Most kids miss school during the month of September because of asthma. They're coming into a new space. So I just wanted to thank you for all the resources, and folks. Amanda really put a lot into the resources that she is making available, and this is basically, I thought I saw close to $1 billion worth of financing resources from those various links. And that's really a smaller percentage of overall of what the National Center of Healthy Housing does. Like, how did you all discover the healthcare benefit financing models?
Sure. Well, before I joined the National Center for Healthy Housing, I was a research scientist with the New York State Department of Health for 7 years. And again, I think I mentioned earlier, I'm an environmental epidemiologist by training. So my job there was really more technical. I evaluated a lot of programs and provided a lot of technical support to the New York State Healthy Neighborhoods and childhood lead poisoning prevention and asthma and other programs there. And honestly, the truth is that I went to a lot of meetings and at first felt sort of frustrated, like, oh, we have all this evidence. Why isn't somebody getting our healthcare system to pay for this and codifying this in some way? And then at some point I realized, well, maybe I'm not somebody, right?
Mm,
Like maybe I just have to sort of take it upon myself. And so a lot of this, again, I was sort of self-taught for me at first. I went into a lot of meetings. People who know me have heard me tell the story how I would go into meetings and sort of scribble down acronyms and then go back to my desk and Google them and sort of try to figure out this healthcare space. And then I started meeting other partners around the country who were also trying to figure it out, and some who were a little bit ahead of me and having some success. And so when I came to the National Center for Healthy Housing, I brought that body of work with me and really set out to help, continue to join that effort to catalyze this opportunity to partner with the healthcare sector and bring together all of this data we have. We have the proven solutions. We've got the data about the return. We know how to find the people and the homes that need these services to help try and sort of bring all of those pieces of the puzzle together. And so the portfolio has just grown over the last decade or so.
absolutely. And thank you for the update, kind of the 2025 version of it all. I appreciate that. So how are you engaging with and how receptive is the building industry, specifically the Maryland Building Industry Association, which is 15 minutes up the street from you and in Fulton in Howard County, and then the National Association of Home Builders, which is probably about 20 minutes south of you in DC. How are the building is the building industry embracing your research?
Yeah, so I can say I think it's sort of uneven. The conversations, because I think there are a lot of shared objectives and vision here. Sometimes I think that the truth of the matter is that, historically, sometimes the concepts of housing affordability and housing stability and housing quality have been seen as an adversarial relationship, that those of us who are insisting on safer homes are inadvertently impacting the supply, adversely impacting the supply of affordable housing. And I think that is a tension that still exists out there. And I've been in spaces in the past couple of weeks where that tension is still real and very fraught. And in some cases, I think because there is a sense that we may be entering a time of more scarcity. Those old tensions even seem like they're sort of coming to the surface even more. One thing I like to remind myself and to challenge all of us with is that we experience these things as very siloed, right? We work in silos, sort of people who are developing new housing and people who are focused on existing housing and rehab, and those of us who care about health and safety, but residents don't, right? For if you are a resident, the fact that you're worried about how to pay your rent next
Right,
month
right.
is completely part of the same problem as the fact that that rent only allows you to rent an apartment that's full of mold and cockroaches, as part of the same problem that you don't feel safe letting your kids play out on the street.
Mhm.
They experience it as one thing. A couple of weeks ago, my staff had the opportunity to be at a conference in Syracuse, New York, where a parent stood up who had been experiencing homelessness and had sought the help of some affordable housing services and gotten a placement where her child was subsequently lead poisoned. And she stood up and her testimony was, if I had known my child was going to be exposed to lead and suffer irreversible brain damage, I would have chosen to stay homeless. And I'm not saying everybody would make that choice, but what I am, I guess, suggesting here is that all of us in this space should be outraged that residents continue to feel like that has to be a choice, that they have to choose housing that's affordable or housing that is safe. I think we know how to do both. I think we have a moral and economic imperative to do so. And so I think there's a real moment here for all of us across the spectrum to come together and to figure it out.
Yeah, shouts out to Syracuse. I wish you were there on better circumstances to hear better news. But that's my hometown, and also realizing that Pioneer Homes, which is just south of Syracuse University on the south side of 81, was one of the first public housing projects to be constructed in the country in the 30s. And so I can definitely see why there's a lot of issues there, on top of Syracuse University having their facilities plant smack dead center of that neighborhood, literally feet away from where people are sleeping.
Absolutely, Aaron. And I want to say also, I was so heartened by how you opened this question, saying that you felt like I was speaking to you, because I think more of us, from affordable housing, from, development, from this healthy housing space, we need to be in conversation and feeling like we're speaking with each other and along,
Yeah.
instead of at each other or past each
Mhm,
other, a
mhm,
lot
mhm.
more. So I really appreciate the opportunity to be engaging with you directly and with your audience here today. I think a lot more of these conversations will give us opportunities also to surface more of those models where this is working to address housing more holistically.
Absolutely, absolutely. I just got one, maybe two questions before I let you go. If you have a few more seconds.
Absolutely.
Okay, so you talked about kind of the climate connection to housing. We've noticed in recent months, weeks, and days how wildfires are affecting that. The ones in California and Pasadena, the one yesterday in Long Island that I saw. Like a whole row of homes caught fire here in Baltimore over the
That's right.
weekend. And so they're just kind of popping up kind of like everywhere because of the connection to climate change. And there may be situations where maybe your home didn't catch fire during the disaster, but living within that soot and that smoke is hazardous as well. And for a lot of people who have no other alternative, they go back into their homes that were affected by some of the smoke, and really could be in a really hazardous situation. How is your organization, the National Center for Healthy Housing, kind of looking at wildfire smoke and kind of how that's playing in, because it's kind of more of a recent phenomenon that's happening in different parts of the country at the same time.
Absolutely. And I appreciate you highlighting that this is not just a West Coast phenomenon,
Mhm.
either. Right. That's where we tend to see the big headlines, but that it really is an increasing threat for communities across the country. So this is an emerging area for us. We have an entire set of pages about emergency response and disaster preparedness, focused on different types of event, from extreme heat, extreme cold, high wind events, flooding, including wildfires. And so we've been working to try and really listen deeply at the state and local level about what the needs are and some of the emerging solutions there. Certainly, as we're thinking about not just wildfires, but the spectrum of climate events, for those that are involved in developing new housing, there's opportunities to really strengthen the way that homes are designed and constructed, the materials that are being used, so that we can make sure that homes are better able to withstand and be more resilient to these climate um, events, right? And for my organization, the way that we influence that is often through building codes processes, right, to help sort of level the playing field and ensure that there's like an even standard being applied within a community and it's not up to individual developers. Uh, but certainly most of us live in existing housing, right? So then thinking about what are the opportunities and interventions to upgrade homes and or equip residents with information so that they can protect themselves. So when you're thinking about wildfire smoke, it's thinking about what are the ventilation systems that are, or in many cases are not available to residents in different types
Mhm.
of buildings, and
Mhm.
what solutions can we offer to them to increase their, the protection that they have from the outdoor air that may be entering
Mhm.
into their home. So there are a variety of resources on our website. This is an area that we continue to build out in partnership with communities across the country.
I appreciate that. Yeah, I've really geeked out on your resources and research on hospital community benefit dollars. Because a lot of these hospitals, especially here in Baltimore, are nonprofit. I was able to find their 990H and
Good,
see
good for you.
see
Well done.
see the many, many millions of dollars, close to billions of dollars that are being spent. Not always, to your point, on healthy housing, and so it's just about making, to your point, the right connections. Bon Secours, Grace Medical Center is doing great things here. Based on your research, I've been able to kind of track what the National Children's Hospital is doing in Ohio, which I think is an awesome example as well. Breathe Easy Homes in Seattle also has some really interesting ways of looking at housing, and I think the thing that I love most about the Be Easy Home case study in Ohio was, a child with asthma immediately moved into one of the homes. No more emergency room visits, no more emergency room admissions, and folks, an emergency room visit is about $1,000. An overnight emergency room admission is close to $10,000. At least here it is in Baltimore. So to have a family not have to have that burden or be that burden on Medicaid, Medicare, or that $3,000 to $5,000 that a family will spend annually just to manage asthma, I think is huge. So thank you for the research and the resources that you have on your website, folks. Definitely check them out. Amanda, is there anything that you didn't mention that you want to say before we close out?
Sure. Well, I'll just, maybe I'll just hit on one more example related to your last point there. Like for example, another opportunity for those of you who may be building new housing and thinking about partnering with a hospital community benefits program or others is, one of the examples that popped up really briefly on screen for those sort of opportunity between climate and health co-benefits was about using electric appliances instead of gas appliances. And I encourage you to go check out those resources. A study that was released by one of our partner organizations in the past couple of years found that a portion of asthma that could be attributed to exposure to emissions from gas stoves and multifamily housing was about equivalent to secondhand smoke, right? Like just let that sink in for a minute. What a huge opportunity that is to just prevent that exposure from happening in the first place and to shift our investment to preventing the development of asthma away from where we invest now, which is on treating asthma. And I think most of us would agree that we'd much rather spend our dollars on an intervention that prevents children from being exposed and having asthma and suffering from all of the hardship for them and their caregivers. And that also yields those important co-benefits for climate, for reduced energy emissions, for reduced home bills, all of the other things that can result from that. So I think that there is a lot of reason to be hopeful here. And I really appreciate, again, the opportunity to maybe spark some additional collaboration between our sectors.
I'm sure you have. Very last question. You're not headquartered in some far off land in the Midwest or on the West Coast. You may have mentioned it earlier, but can you let people know where you're headquartered, please?
Sure. Yeah, we're located right here in Columbia, Maryland. So will you please, like give us a shout electronically, but we're also happy to just meet up face to face and have some of these conversations.
This was perfect, Amanda. You hit it. You nailed it. Hit it right out of the ballpark. Thank you so much for your time, your subject matter expertise, your thought leadership on the topic. This has been awesome. Thank you.
Thank you so much. Appreciate you.
Have a great day.